Ladies and gentlemen, if you'd like to make your way to your seats, we'd like to begin the program. Thank you. It is such an honor to be with you here today. I am Kimberly Souters, consumer investigative reporter from ABC 7 News in Washington. And I just want to share with you a moment before we begin how much the National Library of Medicine helps me as a journalist. In fact, I wish I had picked up this issue yesterday on concussions, because that was the story I covered yesterday. 2 World Cup champs are endorsing these headbands. One of them won't play any longer without these Kevlar headbands to kind of disperse the force that can lead to a concussion. And we interviewed some in the medical community who say they don't believe they'll make a difference because it can't protect the yolk inside the casing, that is our brain and the soft tissue. But I'm a soccer coach and a player, and we had kids try them on, and some thought they were itchy and some didn't like the way they fell down. But I can't imagine how, if 2 players were to collide, there could be some assistance there. And someone brought up to me, it used to be that shin guards were not standard equipment. And will they save you from breaking your leg? No, but I can attest. They offer a tremendous layer of protection. So your publications, Medline, I read every day online, whether it's about immunizations or Ebola or concussions, or I want the therapy dog story, by the way. So if there's anybody who can help me with that, we really appreciate the work you do here today. It's so important, and this day is right in line with that importance. I want to add that we are streaming live, which is exciting. So even though we have this size group here today, the world can listen in to the comments and that are made today and the research that's being shared today. So that's a wonderful thing about the internet. And if you want to know the live streaming link, or you want a loved one to see the back of your head, you can find that link at my Twitter page. That's ABC7 Souters. Suiters, ABC7 Souters. I have it posted there if you'd like to retweet it or grab the link and post it yourself. Confronting Violence, Improving Women's Lives. It tells a story that is unfamiliar to most of us if we are not in the medical community. In fact, within the scholarly community, no one has written about this particular chapter in history. This is a story that is of interest to anyone who thinks about why things are the way they are and how we can improve the lives of others in dramatic ways. To begin our understanding of these issues, I am pleased to introduce Betsy L. Humphries, Acting Director, National Library of Medicine.
Well, on behalf of the entire staff of the National Library of Medicine, I'm very pleased to welcome you all here today. The National Library of Medicine has rich historical collections. We have many historical collections related to nursing. We're very proud of them. And within these collections are many stories, but in my opinion, not many that are any more important or intriguing than the one you will hear about today. You don't solve a problem by turning your head aside and ignoring it. And you can't do important work if you don't work on an important problem. We have many people here today with us. We're very lucky to have people here today who didn't turn their heads aside and actually went to work on an important problem. And in my opinion, there's a long road to go, but we're a lot further along than we would have been if they had not stepped out and done the very important work they did. I am glad we're here with not only to hear about our exhibition, not only to hear about from our distinguished curator, but also to meet some of the people who made this story happen. So I'm very glad you're all here with us today.
I was going to tweet out all those salient things you just said, and you were very quick, so we'll get back to that in a minute. This afternoon, we're going to hear directly from 2 of the researchers who documented domestic abuse and how the medical community could respond. We're also going to hear from the curator, who tells their stories. You're going to learn how nurses are often the first responders to women who are battered. What kind of help did these women receive in the past? Why was it inadequate? Who led the effort to confront violence, and how did they do it? How does change happen? How can you be a part of that change? These are the questions that we have and that our guest speakers are going to address today. As a journalist, it's interesting, the script that was written for me says, I have covered many stories about domestic abuse, but what stands out to me almost more is how many challenges we face as journalists trying to cover domestic abuse. In particular, as you can imagine, there's the great issue of privacy, the even greater issue of safety. Sometimes if there's no documentation, it's a he said, she said situation, and journalists shy away from telling that kind of story. We often do cover the tragic consequences, however, of domestic violence. Police officers tell us that that is the single most dangerous situation they can step into, is to interfere in a domestic violence situation. It's a sad situation, but it happens so often in the newsroom, it'll get back to us from police, or they'll say, oh, it was a domestic, meaning we're not going to go cover it unless it's really, really tragic and there are many lives lost. So it's often an untold story, and we need to do better. We do cover the children who are left behind when there are dramatic consequences. We do cover the women who seek asylum in shelters, but sometimes it's not enough, and especially not enough when we don't cover those who help intervene, who help change lives, which is why this research is so important today. I did interview a woman recently who managed to escape a domestic violence situation, and she opened up a consignment shop out in Loudoun County. And it's amazing to watch her work, because when she helps dress other women, it's not just about finding clothes that make them feel beautiful. It's about helping them to see themselves in a different way. And she gets great pleasure out of that symbolism. And then she also gives quite a bit of her proceeds to support domestic violence programs in the county. I think about the nurses on the front lines and those of you who are in that honorable profession, and how you are the ones who see the trembling lips, who see the bruises that might be hidden, who see the fear behind maybe a difficult, hard exterior. So thank you for your work, and thank you for your research that we want to share with the world today. As we continue here, I want to share that there is a hashtag for this event on Twitter. Again, we do encourage your tweets. The hashtag is NoViolenceNLM for National Library of Medicine. No Violence NLM. Now I would like to introduce Dr. Jacqueline Campbell. She is a national leader in research and advocacy in the field of domestic violence or intimate partner violence. She has authored or co-authored more than 230 publications and 7 books on violence and health outcomes. Currently, she is a professor and mentor at Johns Hopkins School of Nursing and the National Program Director of the Robert Wood Johnson Foundation, and serves on the Board of Directors for Futures Without Violence. Ladies and gentlemen, Dr. Campbell.
Good afternoon. Needless to say, this is an incredibly exciting day. And I want to first of all thank and pay tribute to the National Library of Medicine and all of the people that have worked on making this exhibit happen, making today happen. It's been a wonderful collaboration, and I just am in awe of your ability to make a story come to life with objects, etc. And I know that I've been able to work very closely with people over time. And it's wonderful to know that some of the various scraps of paper that I kept actually will help to tell that story. I want to say that all of the women, abused women primarily, who have been in our research, and forgive me for crying, because I also think about the ones who have been killed. And homicide is where I started. And many of those women who have been killed in a domestic violence incident their mothers, their sisters told us about what happened beforehand. And the thing that we found over and over again was that they had been in the healthcare system before they were killed. And that this was such an important place where we could have identified those women and could have hopefully connected them with the wonderful domestic violence advocacy services, the wonderful shelter network, the wonderful services network that has been built up in this country since we first got started in this field. Great heroines like Janet Reno and Donna Shalala, who made the Department of Health and Human Services pay attention to this issue, that made the the Department of Justice work together with the Department of Health and Human Services. All of that was incredibly important. All of the work that NIH has done in terms of funding research around domestic violence, gender-based violence, all of the forms of violence that women encounter has been awesome. We've got a representative, Mary Rory, here from the National Institute of Nursing Research, and I'm very pleased that she's here. That was where I first received my first funding, first for my PhD work, then for what we used to call a first award for baby researchers that needed help. And then my first R01 was from the National Institute of Nursing Research. I have since been funded by other parts of NIH, for which I am incredibly grateful. The research could not have been done without that funding. We know right now, this morning, there was work in Washington, D.C. to advocate for more funding for NIH. You better believe I got all those nursing colleagues, to get on board about that and be sure and address their congresspeople around that issue and the importance of NIH funding in order to improve the health of the nation. And one of the things that we found in my research is not only are abused women who end up being killed in the healthcare system, where we could do a better job, and we are doing a better job in terms of identifying them and getting them hooked up with the services that they need, but also their health is so profoundly affected in many, many different ways. And I was interested in terms of the mention of concussions when we first started, because one of the things that we're finding is that abused women have had many head injuries oftentimes, plus episodes when they've been strangled or choked to unconsciousness. Both of those things accumulate in terms of problems in the brain. And those, unfortunately, when an abused woman comes into the emergency department with a black eye, oftentimes, although we know that boxers over time have problems from repeated blows to the head, we know that football players, and now we know student athletes, that this is a big problem. But oftentimes when a woman comes into the emergency department with a black eye, she's only treated for that black eye. She's not asked, what is your history of head injuries and strangulation? And yet in our research, we have found that women who are abused are much more likely to have symptoms like TBI, traumatic brain injury, that they are having problems with their memory, they are having difficulty concentrating, as well as some of the mental health effects that they have. And so if we could do a better job in terms of assessing abused women for all of the different health problems that they may be encountering, for their history of head trauma, we might be able to treat them using the wonderful new interventions that we've found for our veterans who come back with TBI. But oftentimes abused women do not have access to those kinds of services. So that's one of the things I've tried to do in my research. I've been enormously collaborative over time, and all of the people that I have worked with, particularly my nursing colleagues, Dan Sheridan, who you're going to hear from next, his wife Marge was on the domestic violence services part at the beginning and was one of those shelter directors that was so instrumental in collaborating with us. Barbara Parker, who in many ways was the first of us to get a major research grant that was from CDC on abuse during pregnancy, and my honorary sister, Doris Campbell, who I have collaborated with for many, many years. And there are other, you'll see in the exhibit, there are other nurses who were part of that. We all worked together. We got a resolution through the American Nurses Association to address domestic violence in the healthcare system. We got that passed in 1991. The AMA came a year later with their attention. I always like to point that out, not that I don't absolutely adore my physician colleagues and the collaborators in this field, but they kind of took all the, as you can imagine, all of the publicity, all of the PR when they came along with their resolutions. But we worked very hard with them. We collaborated with them. Physicians like Ann Flitcraft have been absolutely key. Also, Richard Jones, Ron Ches from ACOG. ACOG was the first of the professional organizations said we have to pay attention to domestic violence, and that was in the mid-1980s. Everett Koop, our former Surgeon General, had the first conference where he brought together professionals from all different fields to say for the first time in 1985 that violence was a public health problem. Until then, we were expected to think about it as a criminal justice problem, not as a health problem. So we all pay tribute to him. The other physician colleagues, Bob McAfee, when he was president of the AMA, was enormously helpful in bringing this issue to healthcare professionals. And now we've been able to work together. In the Affordable Health Care Act, there is a provision now that every well woman visit, which is covered by the Affordable Health Care Act, is supposed to include a screening for domestic violence. Every woman coming in for a well woman visit. When I do other talks, I always ask who in the audience has been screened. And I say, if you have not been asked at your well woman visit, ask your provider why not. Is it because you thought I don't look like an abused woman somehow? That's why we say it's routine screening. It has to be for everyone, because healthcare providers won't know by looking at a woman whether or not she's abused. And then I say, if you were asked, tell your provider, thank you, I'm so glad you did, because they're a little hesitant about this. They're not sure if they're getting into your private business. They may not be sure what to do if you would say yes. So one of the things that we say they need to do is connect abused women up with those domestic violence advocacy organizations that do such a good job in terms of helping us get safety for women, but also that the healthcare provider keep in mind that some of the health conditions she may have may be related to the violence, and that she needs intervention for the trauma from that violence as much as she needs safety. Both of those things have to happen in order to improve her health as well as make her safer in this relationship. We've done a lot. I could go on and on. I want to pay a special tribute to my dean, Patricia Davidson from Johns Hopkins University School of Nursing, who is here, and also one of our junior faculty, Kamala Alexander, who is working on that important interface between gender-based violence and HIV, which is something that we're realizing is very much connected. And again, in order to prevent HIV, we need to address domestic violence, especially in our adolescent girls. So there's many new frontiers to get to. I'm not quite done yet. And I just got a notice of award for a new major grant from NICHD to continue these efforts in terms of making the danger assessment more culturally appropriate for Indigenous women and immigrant women. I will stop there. Again, I thank the NLM. I thank all of you for being here. I know you have very busy lives, and I thank particularly my fellow nurses all over the country, all over the world, especially those here who have worked to confront violence against women.
Thank you, Dr. Campbell. I think about, and this might be too much information, but I'm going to say it anyway. I had an appointment with my OBGYN, and at the end of the appointment, she said, "Is there anything else you'd like to share with me?" And I almost started to cry because I just thought how wonderful that she's taking the time to ask me to open that door. If I needed her, she was there. So wonderful point to be made about a well woman visit and making sure you ask the question, maybe more directly than that, but still. All right, our next speaker is Dr. Daniel Sheridan. He has more than 30 years of experience working with patients reporting domestic violence, family violence, elder and vulnerable abuse, neglect, and sexual assault. He has published more than 35 clinical and research articles on nursing's role in abuse and forensics, and has given more than 600 invited lectures on these topics. While the program lists him as a professor at Goldfarb School of Nursing at Barnes Jewish College, we have a late-breaking update. Dr. Sheridan has just taken a position at Texas A&M, and we are glad to have him here today. Welcome, Dr. Sheridan.
Thank you very much. Just to echo Jackie's comments, wow, what an exhibit. To imagine just not too long ago, I came through these same hallways, through the same security stops, with suitcases full of stuff, stuff that had been accumulated over the years, that they have transformed that beginning, that history, into a wonderful exhibit. Thank you very much. People often ask me, and I think it's because of my gender, how did you get started in this field of primarily violence against women? And I actually first heard the term battered women in 1978. Now that's the same year my wife Marge and I, we got married in 1978. And I learned very quickly the secret to our very long, very successful marriage is I do pretty much everything Marge tells me to do. I have got that yes dear truly down to a science. In 1978, my wife, Marge Josa, and a handful of then very young women in Chicago started Chicago's first battered women's hotline, and I was volunteered by my wife to be a volunteer on the hotline. That was my introduction to this whole concept of family violence, violence against women. Within a few months, that hotline had grown into a battered women's shelter, Chicago's second battered women's shelter, and my wife is now the executive director of the shelter, which meant I was a volunteer at the shelter because I was a safe male. I was married to the boss. Did that work for 2 years as I picked up my prereqs to get into nursing school at Rush College of Nursing in Chicago. I had a previous degree in journalism, didn't have a lot of science background, so I had some prereqs to pick up to get into nursing school. But as a volunteer, I saw that this was much more than a legal problem, much more than a social work problem, that this was a healthcare problem, this was a medical problem, this was a nursing problem. So when I started nursing school in 1980 as a junior nursing student at Rush, I actually helped create what was called then the Rush Coalition Against Spouse Abuse. I actually wanted to name it something like the Rush Coalition Against Violence Against Women, something to have women in there. And one of the female faculty from the School of Medicine said, if you don't include in your name a general term to include the fact that there's battered men, you may not be allowed to continue. I didn't want to change. I wanted to keep it. I wanted to, draw that line in the sand, but I caved in. We actually called it Rush Coalition Against Spouse Abuse and actually did a lot of great work. A lot of the pins and exhibits and things that you're going to see were all created as part of bake sales. We would have bake sales to fund our activities. Not unusual back in those days. I 1982, I graduate with my bachelor's in nursing. The ink's not even dry on my diploma. I go to the director of nursing at Rush Medical Center, and I said, I want you to hire me to set up an ER hospital-based family violence intervention program. She literally laughed and said, come see me when you have your master's degree. Well, so I went and got a master's degree. So 2 years later, with a master's degree, I come back now with a program and a white paper and funding sources, and I was blessed to be able in 1986 open the country's second hospital-based family violence intervention program. 1986, I also got involved in a group called the Nursing Network on Violence Against Women. Some of the founding members of that network are also in this room. They're in that picture that's in a lot of the brochures that you have. Out of that nursing network on violence against women, there was a subgroup of us that we called ourselves the Nursing Research Consortium on Violence and Abuse. And in large part because of Dr. Parker being able to get some institutional support to host us, we had our first meetings. And in that meeting, we would sit together and we would strategize, how could we, even though we're in all different parts of the country, how can we work together to try to get some clinical research around this topic? And back then, there were literally fewer people that are in this room right now. That was it. That was the extent of nurses who were doing work. It was in its infancy. I was able to run that program at Rush for a number of years. And then my wife and I had made a family decision. We moved to Oregon. And in Oregon, I was able to set up a similar hospital-based family violence program and ran that for a number of years. As I was running that program, at one of the Nursing Research Consortium on Violence Against Women meetings, Dr. Campbell, who had been for years giving me encouragement. Well, actually, it was bordered on harassment, but it was encouragement in a positive way. So, Dan, when are you going to go back for your doctorate? Dan, when are you going to go back for your PhD? When are you going to go back for your PhD? And at one of those Nursing Research Consortium meetings, I think it was on a second glass of something red made from grapes, that I said, okay, I'm going to do this. And the topic I picked was harassment. And I was able to do a PhD looking at harassment of battered women leaving these abusive relationships, and was able to created a tool called Harass, and was able to link that tool to increase rates of domestic homicide. Dr. Campbell not only was the person who kept harassing me to get this degree, she ended up being on my committee, and I did that through Oregon Health Sciences University. In 1998, when I completed my PhD in nursing, I did not go into academia. One of the things that I would bring to all of the research consortium meetings was the clinical perspective. I'm an ER, trauma, kind of blood and guts type of nurse. And I would always say, okay, great research, what does it mean at 3 o'clock in the morning in the busy ER when you have that patient, that victim in front of you? So when I graduated in 98, I was actually hired to be an abuse investigator for the state of Oregon. And it stretched me to go beyond domestic violence, beyond sexual assault, into working with elder abuse and abusive people with disabilities. I was very happy in that role until 2001, when I got a phone call from Johns Hopkins University School of Nursing. And basically the question was, how would you like to come to Baltimore and set up forensic healthcare related forensic nursing courses? And I said to Marge, okay, I've got this offer to go to the East Coast, to Baltimore, to set this up. And she said, I've always thought about maybe someday moving to the East Coast, something she had never shared with me in all those previous years. Is there anything else you'd like to share while we're opening up right now? So when we got ready to move to Baltimore in 2001, Marge made me make 2 promises. Promise number 1, that someday we would move back to Oregon. Easy promise. Promise number 2, and she wanted an ocean view home. She remembered both promises. In 2013, when I retired from Johns Hopkins University, we moved back to Oregon, and yes, we do have an ocean view home. It is a bit of a challenge. I still travel a lot, getting to the airport 120 miles one way, but when I get home, it truly is blessed to be home. I'm a retirement failure. After about 2 months of retiring, I was hired by the Goldfarb School of Nursing at 60% to teach online PhD, DMP students. It wasn't involved in the forensic field. It didn't matter. I love to teach. I love mentoring students. And actually, some of the students' topics sort of shifted. I don't know how that happened, but it shifted over into a violence-related area with harassment, encouragement from me. And again, quite happy in that role until just literally a few weeks ago, I got called by Texas A&M Health Sciences Center, College of Nursing, saying we have a pot of money to do extensive multidisciplinary forensic healthcare education, not only throughout Texas, but to make it online and to be able to have it go all over the country and the world. So I've been 7 days on the job now in Texas. I have to again thank Marge for her support. She has supported me every step of the way, because in this new role, I will spend 2 weeks in Texas, 2 weeks at home, 2 weeks in Texas, 2 weeks at home, until we can get all of this online programming up. Because I truly believe that while we've come a long way since 1975, 76, 77, 78, we've only scratched the surface. We need to take a lot of great research, translate it into clinical practice. We need to put a lot more effort into prevention, primary prevention, especially primary prevention. We need to get the word out to men and women, but especially the young boys, that violence is not acceptable. Because if we're going to break the cycle, we've got to get out there and get the word out to our young children. Thank you very much.
Thank you, Dr. Sheridan. If you were going to say you managed an ocean view in College Station, Texas, I was going to be very impressed. A mirage, right. And 2 weeks on, 2 weeks off, that might lead to domestic harmony, so don't. Okay, I'd like to introduce our third speaker this afternoon, Dr. Catherine Jacque. As part of the History of Medicine Division lecture series, Dr. Jacque joins us today. She is the curator of this exhibit. She currently is an assistant professor of history and women's and gender studies at Louisiana State University. She's the author of the research paper From Private Matter to Public Health Crisis, Nursing and the Intervention into Domestic Violence. Previously, she was the Berg-Wallen Postdoctoral Fellow in History and American Studies at Macalester College in St. Paul, Minnesota, and a visiting lecturer at the University of Illinois at Chicago. Ladies and gentlemen, Dr. Catherine Jacque.
Thank you all so much. Let me get my... Let's see. Okay. Thank you so much. It's truly a pleasure to be here. This exhibition has been a labor of love, and I'm so grateful to have been part of it. We've been working on this project for a little over 2 years now, and it's just so wonderful to be here with the completed exhibition and to be here with all of you. I want to thank the National Library of Medicine and also express my deep thanks to the entire staff of the exhibition program here at the National Library of Medicine. Patty Tui, Jiwon Kim, Jill Newmark, Dan Coy, and Erica Mills. I thank you all for all of the hours of your lives that you've spent supporting me in this project, whether that was on email, on the phone with me, scanning images, responding to my last-minute requests. I thank you so much. Also, Patty and Juwan, who have truly been my lifelines and have managed to laugh with me the whole way through, despite the fact that we were working on a very difficult project, but we helped each other through. Confronting Violence, Improving Women's Lives tells the stories of the nurses who changed the medical profession and dramatically improved services to survivors of domestic violence in the late 20th century. Nurses were in the vanguard as they pushed the larger medical community to identify victims of battering, adequately respond to their needs, and work towards the prevention of domestic violence. Now, we're very fortunate, as we heard from Dr. Sheridan and Dr. Campbell, that we have many nurses who are part of that struggle for change in the audience with us. And I want to thank you all for the work that you did and that you continue to do. It truly is humbling to be here with you. You are the history makers. And I welcome you to share your experience with us during the Q&A. In my talk today, I want to take you a bit closer to this story of change and give you a more in-depth look at how this history happened. So first, I'm going to tell you a bit more about the context in which nurses were organizing. I'll give you a clearer sense as to why they were organizing and what needed to change, and I'll contextualize nurses within a larger tradition of social activism in response to domestic violence. I'll also look at the barriers that nurses faced as they advocated and organized in the late 1970s, the 1980s, and beyond. And this is important because it asks us to think about how change happens. So the story that we're telling is not a linear narrative of progress. Things just don't happen that way, right? Things don't simply get better and better as we move steadily forward. It's much more complicated and dynamic. So for a visual rendition, we often tend to think of how change happens. We think, oh, we move from point A to point B, things steadily get better, right? Well, that's not exactly the case, especially not when you're talking about social reform. And so the roadmap for change is actually going to look a lot more like this. And I'm sure the nurses in the audience can attest to that. This is not a story of steady, uninterrupted progress. This is a story of organizing, agitating, falling back, moving forward, going up, down, left, right, every which way until we reach a common goal. Finally, as has been made clear, and as we make clear in the exhibition, domestic violence hasn't gone away. It's an issue that continues to require significant attention, both from within the medical community and outside of it. And as time goes on, we need new methods, new approaches, and new perspectives to deal with this problem. And as Dr. Campbell and Dr. Sheridan have already mentioned, I hope that during the Q&A we can talk further about the challenges that we face today, what is the work that we still need to do. So we'd really love to hear from you all in the audience. So with that in mind, let's start in the 1970s. During the early 1970s, domestic violence remained largely unrecognized and virtually ignored in the legal, medical, and social spheres. Culturally, woman battering was deemed a private matter and one not worth intervening into. Police and medical practitioners alike were reluctant to intervene into these so-called private affairs, or what was then deemed matters between a husband and his wife. When it was acknowledged, wife beating, as it was then called, was a tacitly accepted custom and often the subject of social humor. This is very apparent in an early 1970s ad for a Michigan bowling alley. The copy reads, "Have some fun, beat your wife tonight." So there's clearly that double meaning there. Not just wife abuse, but family violence in general was largely dismissed at this time. Child abuse was just beginning to be understood and studied as a major social problem in the 1960s. And the literature on wife abuse was virtually non-existent. The little scholarship that did exist on violence against wives was mostly found in journals of psychiatry, and it was overtly hostile, suggesting that women provoked their own abuse. The prevailing attitude in the 1970s was that spouse abuse was rare, and when it did occur, it was the product of mental illness or psychological disorder, always on the part of the woman. In addition, there were no reliable statistics on the rates of the incidence of this problem and no legal or medical protocols for how to effectively respond. Not surprisingly then, there were very few services available for abused women in crisis. While there were shelters or temporary housing for those categorized as homeless or displaced, an understanding of abused woman as a separate category of person who would seek shelter or services did not yet exist. battered women found themselves with little to no social support and oftentimes no place to go. So for an example of this, in 1973 in Los Angeles, homeless shelters provided 1,000 beds for men and only 30 beds for women. Similarly, in New York City, there were 1,000 beds for homeless men and only 45 beds for women who needed shelter. There was a radical shift in understandings and responses to women who were battered during the 1970s, and this came as the direct result of feminist activism and the women's liberation movement. Grassroots feminist activists and formerly battered women organized themselves as the Battered Women's Movement. Their slogan, "We will not be beaten." They launched a nationwide campaign in the mid-1970s, and their purpose, in their words, was to name the hidden and private violence in women's lives, declare it public, and provide safe havens and support. The Battered Women's Movement exposed the failures of the law, medicine, and society at large in responding to the 2 to 4 million women who were beaten in their homes annually. So what did these activists do? They organized, they created the first shelters in the country for women who were battered, and they advocated for change. The first battered women's shelter opened in St. Paul, Minnesota in 1974. That's the first one. It was operated and supported by feminist activists, and this was all grassroots. This is not government funded at this time. Similar shelters will open across the country. This massive outpouring of feminist activism and service provision for battered women in the mid-1970s quickly caught the attention of government officials, law enforcement, social workers, and other non-explicitly feminist professionals. By the end of the decade, many groups took on the work of the Battered Women's Movement. Between 1975 and 1978, more than 170 battered women's shelters opened across the country. Many of these were grassroots feminists, others were professional service organizations. In 1978, the U.S. Commission on Civil Rights named over 300 shelters, hotlines, and groups advocating for abused women. In the span of less than a decade, significant gains were made. A researcher in the early 1980s found that the Battered Women's Movement had made substantial headway in terms of providing emergency shelter, legislative reform, establishing or extending government policy and programs, and stimulating a proliferation of research and public information on domestic violence. Noticeably absent from this list, however, was medical reform. Indeed, while an outburst of activity came from the government, law, research, and social service agencies, the medical establishment remained conspicuously absent from the conversation. So now let's turn to medicine and domestic violence at this time, and this will allow us to get a better understanding of why nurses organized and what they were responding to. So some of you might recognize this stock image from the 1970s hit TV show Emergency. Anybody recognize it? Anyway, it's just to get us visually into medicine in the 1970s, so there you go. When nurses began mobilizing around wife abuse in the late 1970s, they faced a dismal situation. Battered women, as a population needing medical attention, were simply not on the radar. While at Yale Medical School in 1975, for example, future physician and pioneer reformer Anne Flitcraft informed her advisor that she wanted to study battered women for her thesis project. Her advisor replied, "What's a battered woman?" This is 1975. Of course, many doctors did know what battering was, and thousands of women who were battered did seek medical attention. Yet the interactions between battered women and their doctors during the 1970s reveal a widespread pattern of medical dismissal of patient complaints and the overall non-involvement of doctors into the causes and remedies for battering. In a letter written in the early 1970s, one battered woman described the medical neglect she encountered after a series of excessive beatings by her husband. First, she went to her local clergyman, who told her to, quote, "be more tolerant and understanding." and, in her words, to quote, "forgive him," her husband, "the beatings, just as Christ had forgiven me from the cross." True story. She next turned to her doctor for help. She reported, "I was given little pills to relax me and told to take things a little easier. I was just too nervous. I did go to 2 more doctors. One asked me what I had done to provoke my husband. The other asked if we had made up yet." Her story is consistent with accounts from thousands of other abused women at this time. Medicine typically constructed the battering as a private event, one that the provider sought to keep at a distance. As one doctor explained, when presented with a woman who he suspected may have been hit by her husband, "We don't have time or the inclination to go into sociological background as for the reason of the assault. It's a personal problem between a man and his wife." Additionally, the dominant medical opinion saw battering as the result of the woman's own psychopathology, be it her alcoholism, depression, emotional instability, or other psychiatric problem of the victim. The medical treatment of battered women was limited to the issue needing immediate attention, be it a broken arm, a laceration, or other injury. An emergency department surgeon perfectly encapsulated the mindset of medicine vis-a-vis battering when he said, "It's none of my business who hit her. I'm just here to treat her." How the injury happened was irrelevant to the physician. As one group of researchers commented, the fact that the injury was caused by a punch is no more significant than if it resulted from a fall. In this context, some reform-minded individuals began to speak out, redefine the problem, and advocate for significant medical changes. Beginning in the late 1970s, nurses from California to Kentucky, Maryland, and Boston would be at the forefront of identifying battered women as a population with specific needs and implementing better health provisions for them. So how does all this happen? How did nurses come to consciousness about this issue at this time? Well, there are several ways that this happened. For some, it was their proximity to the patient. Oftentimes, the nurse was the first or only person who a battered woman ever disclosed to. As one reformer explained, because of their unique role in healthcare, nurses are often at the cutting edge of exposing and treating this form of abuse so carefully hidden from others. Another way nurses came to consciousness was through their research, and I'm going to focus on Jacqueline Campbell's story here as an example of this. In the mid-1970s, Campbell was a master's level nursing student at Wright State University in Dayton, Ohio. As part of her master's work, she was assigned to do prevention work with an identifiable group. She did some research and found that the #1 cause of death for African American women in Dayton was homicide. At first, she assumed that her training as a nurse was not useful for homicide prevention. She remembers thinking, "I don't know what to do with that. I'm a nurse. That's criminal justice stuff." But her advisors insisted, and she pursued the research. The results were striking. Over 70% of the women who were killed by current or former partners had a history of domestic abuse. Many of these women had sought medical services prior to their death, yet had not been identified as victims. Campbell realized that identifying abused women when they sought medical services could literally save lives, as she's mentioned earlier. From this research, she wrote her thesis and, as she remembers, clearly gave her a roadmap for the rest of her life. Campbell's story is instructive because it also speaks to the immediate issues that nurse reformers sought to address. First, there was the issue of identification, recognizing that a patient was a victim of abuse. Now, as it turns out, researchers found that battering was 10 times more frequent than physicians acknowledged, when they acknowledged it at all. Second was redefining the issue that needed treating. Now, this called for a much more comprehensive approach, not just treating the physical injury in isolation, but understanding and responding to the context in which that injury occurred. And third, leading out of those, was prevention. And this included things like providing resources and referrals and helping the woman to help herself. And the goal of this was to reduce further harm, and hopefully, eventually, the woman would get out of her abusive situation if possible. So what do nurses do? They research, they publish widely on their findings in major medical journals and nursing journals. They initiated programs and protocols at their hospitals to provide better services for women victims of domestic abuse. In a very early intervention, emergency department nurses at Brigham and Women's Hospital in Boston initiated and implemented the country's first hospital protocol for the identification and treatment of battered women, and that was in 1977. So what does a protocol like this look like? Well, the first order of business was properly identifying survivors of domestic violence who came to the emergency room. At Brigham and Women's, identification began with the first person who the patient encountered when they entered the ER, the secretarial staff. Staff were trained to pick up on cues and alert a nurse immediately when battering is suspected. From there, the examining nurse was to approach the patient openly and sensitively, using techniques of crisis intervention, and offer counseling services. If she agreed to counseling, the woman would then meet with a social worker who would provide emotional support, information on legal options and resources, as well as information on shelter services and other community resources available to reduce harm and, ultimately, end the battering. This method was rooted in the belief that in these supportive and affirming encounters with hospital personnel, the woman may, and I'm quoting from the protocol here, perhaps see things differently and consider new reactions or ideas that she might previously have thought impossible. This period is crucial for her. This is the best time for her to mobilize her energy to create a second chance for herself. Successful management of the current crisis may well result in increased ability to cope with future crisis. In the first 3 years of service, the program at Brigham and Women's identified 211 battered women, all of whom received referrals to social services for further assistance. This was significant as prior to the implementation of the program, few battered women who came to the Brigham and Women's ER had been either identified as such or given resources. In other cases, nurses reached out to existing services outside of the medical community. So also in 1977, nurses at Hennepin County Medical Center in Minneapolis were seeing increased numbers of severely beaten women in the emergency room. The ER staff, including nurses, felt helpless at their inability to intervene effectively as they faced limitations of time, knowledge, and resources. The ER nursing supervisor reached out to the Harriet Tubman's Women's Shelter for assistance. The volunteers at the shelter created a women's advocacy program at Hennepin, the first hospital-based advocacy program for battered women in the United States. The role of the advocate was to support the battered woman in coping with her emotional reactions to violence, help the woman regain her self-esteem, and encourage her to discover her own strengths and give her support to act on them. So again, very similar to some of the work that was being done at Brigham and Women's in trying to help the woman to help herself. Across the country, nurses collaborated in various capacities with existing organizations. Some began to provide medical services to survivors at their local shelters. Others joined local domestic violence task forces. Others facilitated support groups for survivors, as just a few examples. Oh, I'm sorry. This was the guidelines for the hospital advocacy from Hennepin County. So I'm just a slide behind. In the mid-1980s, nurses helped to create and implement hospital protocols for treating battered women nationwide. Now, I mentioned the Brigham and Women's protocol from 1977, but you see a burst of these protocols being written beginning in the mid-1980s, 84, 85, 86. In Chicago, Dan Sheridan created one of the nation's first hospital-based family intervention programs. The program opened at Rush Presbyterian St. Luke's Medical Center in July of 1986. He had actually created this program while in nursing school, as we heard, as part of his master's level coursework. Sheridan was a trailblazer at Rush, and throughout his nursing education and later his career, Sheridan pursued his goal of trying to get medical people to look at spouse abuse as a medical problem, right, which he spoke to earlier. The amount of work these nurse reformers took on was tremendous. By 1987, nurses and their allies had created approximately 100 initiatives at state and local levels to train hospital staff and other healthcare personnel about battering. And it was right about this time during the mid-1980s that nurses formally organized. Up until this time, many nurses either worked individually in their respective locations or were parts of informal networks across the country. In some instances, nurses were wholly unaware of the work that was transpiring in other towns and cities. A significant shift occurred in 1985 when nurses formally organized. In October of 1985, the Surgeon General C. Everett Koop held a 3-day workshop on violence and public health in Leesburg, Virginia. The workshop brought together over 150 experts from across the disciplines to discuss recommendations on the evaluation, prevention, and treatment of various kinds of violence, and this included spouse abuse. This is a very critical moment in the history of medicine. As reformer physician Anne Flitcraft remembered, this unprecedented workshop marked a turning point in public health officials' involvement in domestic violence. This is critical also in that it brought together for the first time many of those in the health field who had been researching, writing, and working on domestic violence for over a decade. This was especially true for the nurses who attended the Surgeon General's workshop. Gathered together for the first time, they decided to form the Nursing Network on Violence Against Women. This organization was the first of its kind in the country and was formed to encourage the development of an informed nursing practice on the range of health issues relating to violence against women. And that organization still exists today. It's now global in scope, and it's the Nursing Network on Violence Against Women International. The Nursing Network held their first national conference on violence against women 1 month later in November of 1985 at the University of Massachusetts at Amherst. There were 150 people in attendance, and the conference provided a forum for nurses and other healthcare providers involved in the area of women abuse to meet, share knowledge and ideas, and gain support for their work. The Nursing Network would continue to grow over the following years. At the second conference, attendance increased from 150 to 250. The organization worked to disseminate health-related information on violence against women by holding biannual conferences, publishing a directory of members, publishing a regular column in the nursing journal Response, and maintaining a list of protocols and training manuals for working with battered women in hospitals and shelters. Now connected via a national organization, nurses would continue the critical work of reforming the healthcare system. Now, as I mentioned in my introduction, change is not always easy, and it's not always steady progress. So despite the incredible outpouring of activity, nurses and their allies still faced enormous hurdles. The overall medical trend of dismissal and outright hostility towards battering and battered women continued well into the late 1980s. In a 1987 study of 3 emergency rooms in a large metropolitan area, researcher Demi Kurtz found that only 11% of the 104 battered women who sought services encountered staff who took the woman's battering seriously and viewed it as legitimately deserving of their time and attention. 2 years later, pioneer reformer and physician Carol Warshaw also critiqued the continued failures of the medical system when treating battered women. She argued that medical professionals routinely failed to make the connection between the patient's injury and how it happened, who did it, what her relationship to the perpetrator was, what its impact was, and what the implications and meaning were for the woman and her life. There remained oftentimes a singular focus on treating the presenting injury and nothing else. This left battered women in a perpetual cycle of abuse, receiving medical treatment only for the presenting physical injuries and then being discharged from the hospital only to be readmitted again in the future with new injuries. Nurse Dan Sheridan spoke to this typical emergency room response as a "we treat 'em, we street 'em" approach. Medical staff operated under the assumption that it wasn't worth any further intervention because of this belief that battered women all go back anyway, and the expectation was, oh, she'll be back in the ER next weekend anyway. Writing in 1991, two reformers put it bluntly, and I quote, "Neglect, denial, mistreatment, and punitive interventions and referrals characterize the ongoing care of women who present with abusive injury. This increased the woman's risk of injury from battering and perpetuated the cycle of violence for millions of women nationwide." In seeking to reform the healthcare system, nurses and their allies confronted a long history of dismissal, denial, and neglect of battering and battered women, a pattern that was difficult to break. Despite this, nurses kept agitating, kept organizing, kept researching, and working for change. And they continued to make critical progress. A case in point is when professional organizations recognized domestic violence as a significant medical issue and urged their constituencies to take action. This reinforced over a decade of advocacy and activism by nurses and their allies. The American College of Obstetricians and Gynecologists, for example, announced a campaign to combat domestic violence in January of 1989. That same month, the organization released a technical bulletin titled "The Battered Woman," which is here, which outlined the definition, incidence, and public health impact, along with the importance of identifying abuse victims and methods for intervention. In another example, the American Medical Association issued diagnostic and treatment guidelines on domestic violence in September of 1992. These guidelines were prepared by pioneer reformers, including Anne Flitcraft, Susan Hadley, Carol Warshaw, none of whom were actually members of the American Medical Association, but all of whom who had been working on domestic violence along with nurses for over a decade. Recalling the publication of the guidelines, Flitcraft explained in an interview that these guidelines gave the imprimatur of real medicine. This says, violence against women, domestic violence is real medicine. These were critical turning points. Although they still faced a long road ahead, nurses had made significant gains by the early 1990s. In 1992, Jacqueline Campbell could write with confidence, "No one doubts anymore that violence is a serious health problem. No one doubts that the healthcare system must become involved in decreasing violence." Nurses played a critical role in that transition. As they came to consciousness about the issues facing battered women, nurses advocated, educated, and organized nationally. In various capacities, nurses sought to both alleviate injury and ultimately prevent violence against women. Their impact was significant. Following 15 years of working in education on the issue of battering, Campbell wrote, "I'm deeply gratified to see the official health policy-making bodies recognize what many of us in nursing have been working on for a long time. I am proud that nursing has taken a leadership role in changing healthcare policy about violence." Now, I'm going to end my talk there because I want to leave enough time for question and answer, and I want to hear from the reformers who are with us today. But in closing, I hope that one of the takeaways from this talk and of this exhibition is that all of these people who made an extraordinary impact were also ordinary people. They really are just like you and me. And that any of us can make change. We can all be history makers. And it's just a matter of getting out there and working for what we believe in. So I hope you all will gain a sense, or I hope you all have gained a sense, of just how far we've come in terms of medical reform, but also realize that we have a long way to go. But we all have a hand in shaping the direction that this story goes. Thank you so much.
Wow, I want to hear about the next 20 years. Dr. Jacquet, thank you so much. I'd like to invite all three of our speakers back up to these chairs here so we can have a Q&A session. And we might even check our Twitter feed, too, to see if anyone out in the universe has questions that they would like us to ask of our panelists as well. You know, as Dr. Jacquet was speaking, I had forgotten, I shouldn't say I had forgotten, I was reminded, sadly, that the leading cause of death for a pregnant woman is homicide. The leading cause of death for a pregnant woman. And in the newsroom, when we do hear of a woman being killed, it's one of the first questions we ask is, well, was she pregnant? It can make women a target, does make women a target. Very sad state of affairs. Thankfully, we have those on the front lines who are really paying attention to these issues. So we would like to open it up to your questions. Please just raise your hands. We have assistants with microphones. Any one of our panelists here is, and if there are any follow-up comments you all would like to make, Dr. Sheridan or Dr. Campbell or Dr. Jacquet? Don't be shy. There we go.
I have a question about the history. I'm wondering if the influx of women as doctors, the increased number of women physicians influence that story at all.
I'm just going to repeat the question. The question is the influx of an increasing number of female physicians. Has that impacted the trend toward paying more attention to this issue?
I would argue absolutely yes. During the 1970s, a lot of the examples I was talking about, physician was white male physician, right? And so I think as we see in the 1970s, as women are accessing legal fields, medical fields, right, all these other domains that were historically reserved largely for white men, as more and more women become part of those fields start to change. So I think having more difference, but also I think even regardless of that, all the work that nurses were doing, this change was going to come, right, regardless of that. And I don't know if you all would have anything to add to that.
Definitely that had a lot to do with it. Part of it, you noticed many of the early physician heroines in this field were women. However, the leadership of the physician organizations at that time, and still now pretty much, are men. And so it was a matter of those female physicians collaborating with male colleagues and helping them see those issues. And, I always think that the head of ACOG, Richard Jones, was, an absolute pioneer in terms of convincing his male colleagues. But there's several different stories to tell, but one of them that I always remember was in 1992, the AMA had this groundbreaking conference that was for medicine and the law to start collaborating to address domestic violence. And when the call went out for abstracts, for papers, for people to speak, nurses were neither invited nor accepted. And none of us could even go. And I remember at the time thinking, well, really? And so, and talking to my physician colleagues that I've been working with for many years about, how we were, felt completely disrespected in spite of the work that we were doing. And having it explained to me that they felt like they first needed to have physicians on board. And that because the physician role and the nursing role were so different, that it wouldn't be useful to have nurses speak to the audience because, what they had to say might not be taken seriously. And I love that photograph of the nurse and physician back then, which was very iconic. And we were all taught, in nursing school, I went to Duke, great school of nursing. I went to Duke in the 60s, late 60s. And I was taught to rise when the physician came into the nurse's station and to offer to get that physician a cup of coffee and whatever patient charts he wanted. And if we were busy working on a patient's chart, if the physician came into the nurse's station, we had to totally give it up. It didn't have anything, We were clearly in a very subservient position. And so part of what was going on during that time was around the feminist movement was also in part getting more physicians, female physicians, into their profession, but it was also elevating nursing so that we are now much more respected both for our science, for our practice, that we are partners with physicians. But all of that was somewhat confounded because, I know my own School of Nursing, Duke, closed as a baccalaureate program because all of the talented young women were now going into medicine. So there was, there were a lot of forces in play along with the battered women's movement and the feminist movement. And I cannot say enough how important it was for shelters to get started. And one of the things I forgot to say is that Barbara Parker, not only a nurse extraordinaire, a nursing researcher extraordinaire, she was also a founding mother of the House of Ruth, Maryland, which is one of the leading domestic violence shelters in the country. I must say, I've been on the board. There's many things, many conflicts of interest there. But that's an example of how nurses were collaborating around the whole issue with the domestic violence shelters, et cetera. And we would go to them and talk to those shelter directors, what is the research that's needed? And we asked women, what do we need to find out that would help in terms of addressing your needs more completely? And I think that's been a hallmark of the nursing research, that it's not only incredibly collaborative, and if we hadn't have all worked together, I loved what you said about it is possible to make change. It is absolutely possible to make change, but it's really hard to make change in this country all by yourself. That you're much better off if you join with others of like mind. And as I started, the particular collaboration that I think I'm most proud of in nursing research is with the women. And yes, there are men that are abused. Yes, we care about the children that grow up in these violent homes, and we certainly want to help them, and that's where prevention lies, and some of them are young men as well as little boys as well as little girls. But still, the most violence in families and in relationships is against women. The most severe violence is against women. The women who come with the people that come with injuries from domestic violence are most likely women. And the ratio of people killed in domestic violence incidents is either 5 to 1 or 4 to 1, depending on the year and the state. In terms of women are killed far more often in this country than are men. And we've decreased that homicide, and hallelujah. That's something that I've really, really worked on, but it's still not down to nothing. And, that for me is when we, and sometimes we get into arguments about who's abused the worst and who, and the other thing I oftentimes think of is in Baltimore City, which is where I live proudly in the city. It made all of the newspapers and the televisions back in April. And one of the things that I would think about as I saw the footage of some of our young people picking up concrete blocks and throwing them at police is how many of those young people grew up in homes where they saw their father beat their mother or were abused. and have those trauma trails, is what I call it, in their whole body, where when you've been highly traumatized, the cortex does not kick in. You know, the impulse to either fight or flight, the reaction that somebody's out to get you, that you better fight back or you better even hit first, is part of that trauma response. And that's not to excuse any of those young people that did that behavior, but that's that we need to do a better job of understanding where that comes from. And like I said, working with those children who are growing up in homes where they see their father beat their mother. And
Dr. Campbell, I wanted to follow up just briefly on the Baltimore situation. Did you see the video of the mother who was just wailing on her son?
I certainly did.
And so there was a debate, was she Mother of the Year, or was she giving us a glimpse of what life can be like in that community when you're trying to get a point across, and it's a matter of life and death?
I recommend to you all, it's not an easy answer, okay? But Jacquet's new book is a very powerful one. It's very skinny in terms of what it's like to grow up in inner city Baltimore or many inner city communities, including inner city Washington, D.C., and why parents in those communities maybe too often resort to the belt, that physical punishment is a fierce way of trying to protect your children and not realizing what the damage is. And you know, what I teach our nursing students is you can't go in and say it's a bad thing to hit your child. It's a bad thing to use physical discipline, because you are going to just so turn them off. And that what you need to do is help them understand a full range of behaviors that can help correct a child. But I think that's absolutely something we as researchers, we as advocacy communities, we as healthcare professionals have to work very hard to help parents at least use physical punishment less often. So that's a
Dr. Sheridan?
complicated answer.
The issue of, I want to say that working with women who are in abusive relationships, working with women who have been sexually assaulted, should not be a gendered issue as far as the people that intervene. This is also being telecast, and I hope it's going to be seen by a lot of students in a variety of medical nursing professions, is that if there are men out there, the ability to be empathetic, the ability to share concern, to be able to ask in a non-judgmental way, be open to the response, the ability to say, I'm sorry that happened to you. Thank you for sharing that. That's invaluable. And whether it's men or women, and was it more women coming into medicine that has pushed this forward? Maybe, maybe not. Because we've had women in nursing. I was struck by that picture with the nurse in the front and the doctor behind. I want to juxtapose that with the picture that you've seen here on the board and also in the brochure, where here are a bunch of our early nurse leaders in domestic violence, and here I am sort of squatting, kneeling down, and somebody sitting next to me here, his hand on my shoulder, not in a one-upsmanship, but in a helping, mentoring way. I remember back in 1980, I was a junior nursing student, and I wrote a letter to the editor, to the American Journal of Nursing, saying, help, are there any nurses out there working in shelters? I'm a volunteer at my wife's shelter. And I had about 3 nurses write, Dr. Campbell, Dr. Parker. And I actually saved those original letters. They're somewhere in the materials that I gave here. And little did I know, I mean, this was like, Dr. Campbell, Dr. Parker. It's like, wow, I'm a junior nursing student. Like, this is like amazing. And they've become mentors and friends and have welcomed me as a man, but also as a nurse, and empowered me to be able to go out and try to make a difference in my career. And I think that's the important thing, for us to be able to reach out and mentor that next generation and the generation after that generation, all of us have been in this field long enough that we provided direct intervention services to battered women. We've now then actually worked with their daughters, who were then adults, and we're now beginning to work with the granddaughters of some of the people that we worked with initially who are now adults. So this is an intergenerational issue. And being able to continue to care and be empathic is the take-home point. Probably less so than the gender, the caring and the empathy, which really is embodied in everything that we are taught from day one of nursing school.
It's a wonderful thing that healer does not have a gender associated with it, does it? You have a question?
Hi, thank you for the history. I just wanted to also point out that one of the major changes in the healthcare field that really began to look at domestic violence a little more was looking at the issue of violence in pregnancy and the relationship to low birth weight. Because when we first started doing this research, like it was said, it was just a family thing. But when we could show that it made a difference in low birth weight babies, when everyone was very interested in how to prevent low birth weight. So that whole movement of violence in pregnancy was also parallel to the other movement.
The point being made about violence in pregnancy and the incidence of low birth weight and the impact on the fetus and goes far beyond those of us right here and right in the children involved.
Right, and part of the one step forward, a couple back, or half of one back, and then 2 steps forward, one of the things that Barbara Parker and her colleague Judy McFarlane, who was another one of the early pioneers in this movement, taught us was that oftentimes both policymakers and government officials, and this has been true all around the globe because we're doing work on violence against women all around the globe now, is if you can show that women are hurt while they're pregnant by partners and that babies are affected, then it's clearly a big problem. And there was a couple of moments during this history where I can remember, what are we as women? Just baby carriers? Do we only count when we're carrying a baby? But then again, thinking, well, how important is it that we do reach out to women who are abused during pregnancy so that there's more chance of that baby growing up in a safe home and not witnessing domestic violence between that baby's parents, as well as being prevented from issues like low birth weight, etc. And so nurses have continued to be very much in the forefront around the issues of abuse during pregnancy and abuse before pregnancy and abuse after pregnancy, around the health of those children. But always keeping in mind that the woman, may stay abused long after she's pregnant, and we need to care then too. The other thing around that brings to mind around that particular issue is what was stated before in terms of maternal mortality, the leading cause of the leading cause of maternal mortality in the state of Maryland, where many of us live, is homicide. And most of those homicides are from a partner or ex-partner of that woman. And most of those women, and Diana Chang in the Maryland Department of Health and Mental Hygiene has done a wonderful study of this. And most of those women were in the healthcare system in prenatal care before that homicide occurred. And yet again, and this is in 2005, again, we were somehow not picking up that they were there, that they were abused, and getting them to the appropriate services. So,
Well, and that is the bastardization of understanding, right, that women aren't just carriers of babies, but that there is a power in carrying creation And for those who don't want power taken away from them, it's why the women become the target.
And if I'm sorry to keep jumping in, but one other thing that oftentimes people think, well, that physicians and nurses should get women to leave, that they need to leave that abusive relationship, that that's the solution. If they would just leave and not, or leave and stay away and not come back. And I think one of the things we've learned over time, again, from the women we have talked to in our research and in clinical practice, is that they need to have a choice of options, that they are with this person for a reason, and it's not always a heterosexual relationship, it can be a same-sex relationship. They're with this person for a reason, that they want this relationship to continue, especially if he's the father of the children, or if it's a parent that's a co-parenting a child, that they want that person to stop hitting them, stop hurting them, but not necessarily to leave that person entirely. And that we need to understand that she needs a variety of choices, of options. She needs to learn all of the options that are available for her. And we need to not push her to make a certain decision, but to make an informed decision that is right for her.
Well, and continuum of care, of course, is so critical because most battered women, of course, will tell you, well, if I leave, he'll kill me. So asking the question isn't enough. Knowing isn't enough, right? Helping them through that safe path is critical. Yeah.
Yeah, and just to add to that, it's incredibly difficult for abused women to leave their abuser for a variety of reasons. And also, as you mentioned, the moment when the woman is about to leave is the most dangerous moment. That is when her risk of death or injury is at its highest, right? So I think a lot of the work is understanding the situation that women who are abused are in and being empathetic to that, and that it's not just a simple, oh, she can just leave, because no, she cannot. It's a lot more difficult than that.
And there's women who are contemplating leaving. There are so many barriers. And I often in my trainings talk about the F words you can say in public. Battered women hear that other one all the time. But when you begin to look at some of the barriers, fear, if you leave, I'll kill you. Or go hide in one of those shelters, I'll kill your mother. Your sister will be tomorrow morning's headline. Finances, major barrier to leaving. Father, she wants those kids to have a father. Forgiveness, many times after a man will beat a woman, he'll shed real tears and he'll apologize, I'm so sorry, and she'll forgive him time again. She called every shelter in a 3-county area, and she heard, sorry, we're full. She's got a fantasy she's going to fix him. And those are some of the barriers, actually, she has some control over. And are there any, by the way, are there any fixers in this room today? Nurses, social workers, and physicians, we're all fixers, okay? And we sometimes have this fantasy that we can fix other people when really the only people we have the power to fix would be ourselves. I call it the phyto-feline factor. If there's a pet in the home, and if they leave and leave the pet behind, he may very well kill that pet, unless they can get a shelter for that pet. And many battered women shelters now partner with animal rescue or animal shelters. She may be familiarity. She watched her grandmother be beaten, her mother be beaten, and her sister was beaten, and now she's being beaten. I've actually had women say to me, well, Dan, don't you beat your wife? Don't all men beat women? And the answer is no. There are some, yes, but many, many men don't. And she may be too fatigued, too tired, too exhausted. And this is when women will present to the healthcare system with alcoholism, they're using alcohol and drugs to self-medicate. They are going to present with depressive symptoms, suicide ideations, but not as an underlying endogenous disease, but as a sequelae of living in those abusive relationships. So the more that we, and every single person in this room, and every single person who's watching this, the more that we can address even 1 or 2 or 3 of those barriers, the more likely she will be able to come up with a plan to be able to leave safely when she's ready. Not when we want her to, when she's ready.
That was a lot of F words. I was trying to write them all down. Go ahead.
First of all, thank you all for these wonderful talks and the NLM for creating this exhibit. I think it's Dr. Sheridan, but if he could comment on the emergency room department and how those changes and maybe the forensics, the development of those, and obviously the interface with the legal system and so forth.
The Emergency Nurses Association, which I've been a continuous paid member, I think, since about '85, somewhere around there, really was very important in coming up with some of the first statement papers talking about the need for emergency nurses to be involved. Not only was I involved from the second year that the Nursing Network on Violence Against Women created, I kind of joined year 2. I actually joined year 2 the International Association of Forensic Nurses. That started in 1992. I was invited to come to their inaugural meeting in Minneapolis, but I had just started a PhD program, could not afford to go. I actually joined in 1993, and many of our members, 3,000 plus members of the International Association of Forensic Nurses, are emergency room nurses. And they are also the same nurses who are doing a lot of the sexual assault forensic exams, but a lot of the what we would call SANE programs, sexual assault nurse examiner programs, are broadening their interventions. In Maryland, when I lived here, we were never sane in Maryland. We were safe. For many years, we were sexual assault forensic examiners because when it was founded, there was one physician assistant who was a part of that founding group, and so they couldn't use the nurse word. But about 10 years ago, the Maryland Board of Nursing, which regulates forensic nursing practice, changed our name to FNE, Forensic Nurse Examiner, because a growing number of programs in Maryland and New Jersey and Delaware and other places around the country, those nurses are being called anytime a battered woman presents to the emergency room, child abuse, elder abuse, even just the random violences, those victims who present, forensic nursing is intervening. So we have these two sort of sister organizations. We have the Nursing Network on Violence Against Women International. We have the International Association of Forensic Nurses, who work often collaboratively in many dual memberships to be able to do the clinical, the 2 o'clock in the morning, how do you deal with this at 2 in the morning, by using some of the wonderful research done by the Doris Campbells and the Barbara Parkers and the Jackie Campbells and many of our colleagues. How do you translate that into clinical practice? And so I think emergency room nurses have been, and I hate the word cutting edge because that's what we see a lot of, is those sorts of injuries, but truly have been at the forefront of and continue to be leaders in providing that emergent care. But that's not primary prevention. We're putting Band-Aids still. Now, we're no longer treating them and streeting them. Many of our programs are doing a lot more services versus, putting the Band-Aid and sending them out the door. But we truly, and I believe, and maybe it's just I'm getting to that age where I have a little bit of wisdom, not too much yet. Guys, we're a little slower in getting there. But to be able to say, what can we do to prevent? How do we get to the next generation? And the generations yet to come. So I think that's where we need to be looking at some of that prevention.
Yes.
So, following up on what you just said, you guys were outstanding. I want you all to think about or share some examples, if you know, of the role of precision medicine, health, big data, microbiome genetics, and its impact on battered women research.
And if you do that in 30 seconds, please.
Yeah. Good luck.
All right,
Good
30
luck.
seconds. Thanks, Mary. All right, just a couple of, we do have a great nursing research study that has shown that women who are abused have issues in terms of telomeres shortening, and as we know, which has to do with premature aging, et cetera. There's new research in the elder abuse field in terms of what does long years of being abused, which may start in childhood and going up all the way through adulthood, do to women's cognitions, and is that part of just a part, not all of, but a part of the gender discrepancy in Alzheimer's disease. So that's, just a couple of different ways that the science is going. And I do need to put in a plug for nursing research. We nurses do nursing research. We create nursing science. Some of it's forensics, some of it's other kinds of nursing science. It's not medical research. We oftentimes collaborate with our colleagues in doing our studies, who are physicians, and welcome that colleagueship. That study of telomeres done by Janice Humphries was done with a physician colleague. However, I think it's important sometimes if the public realize that nursing it's a distinct discipline with its own science.
We have time for one final question. Yes.
It was the role of shelters in providing a safe place to go. I was wondering what kind of impact or role the internet has had in offering a safe and virtual place that women can go to for help and advice while remaining anonymous until they're ready to seek more help in person.
Actually, one of our nursing colleagues, Nancy Glass, has developed and is testing a decision aid that allows women who are abused either in the healthcare system, because many women don't have access or safe access to the internet themselves, but actually use a computer in the healthcare setting or a tablet to go on this website and work their way through some different options that they might have around abuse. And it first asks them, first of all, how much danger are you in? It uses my danger assessment to calculate the danger of the woman. And then it asks them what their priorities are in life. If they have children, if keeping those children safe and healthy is their biggest priority, or if they're in school, if that's their biggest priority, or if they have a job or want to get a job, that's, so the suggestions in terms of safety planning have to do with where she is in life, where her priorities are, and what she wants to do about this relationship. Does she want to keep it? Does she want to leave it? Or is she not sure, because the safety planning has to be different? And then it works her way through some safety planning strategies. There's also, this has been turned into an app. There is an app for that. And it's called My Plan. And the wonderful thing about My Plan, and you can get it through the One Love Foundation website, the wonderful thing about My Plan is that friends or family can do it also. So if there's a woman in your family or a friend of yours that you're worried about, you can go to My Plan and work your way through, again, some of the things that you as a friend or family member might help them with. And finally, I have to say, Futures Without Violence has been our partners throughout all of this. There's all kinds of free materials available there in terms of both for the healthcare setting and for the issues around abuse and health that are there. And there's a lot of really good materials, including some prevention materials like the Coaching Boys into Men campaign. All of those materials are free. So that's funded through the Department of Health and Human Services. There are a lot of fabulous websites, thank goodness. There's the National Domestic Violence Hotline, where any woman can call and or email and or text to get some help with these issues. So fortunately, we're very lucky in this country. We have a lot of services that are working together with those of us in the healthcare professions who are working on this issue.
There are all these apps popping up, and just a few years ago I would have no idea what an app is. I have a smartphone. I'm not the smartest user of a smartphone, but I think we do need to, look at how do we better keep track of, organize, and have where people can go to a central location to find some of these apps. For example, where I still keep a clinical practice in Baltimore Mercy Medical Center, their Forensic Nurse Examiner program has an app called Be More, in a short acronym for Baltimore, Be More Safe. And in that app, which gets a lot of hits, young women who can navigate all of these apps and these sites much faster than I probably ever will, can go and get those resources. So I think that's one of the next steps around the prevention is the continued development of quick, user-friendly, well-known, well-advertised apps and tweets and all of these things that are the technologies that are developing and expanding, to be able to use those to be able to reach the next generation and the generation after that one.
Before we wrap up here, a technical note, the conversation will continue. Of course, we invite you to come next door to see the exhibit and learn more in the National Library of Medicine building adjacent to this building. Staff members are going to raise their hands so they can help us find our way to the exhibit and the reception. We want to thank the Friends of the National Library of Medicine for sponsoring the reception. And a few just quick takeaway pieces, I think, from Dr. Sheridan, we really heard about how men are an important part of this and that their empathy is just as important. And from Dr. Campbell, it really stuck with me. Make sure you are asked that question. Are you having trouble at home? Are you abused? Is there something you need to tell me? And then Dr. Jacquet, and your labor of love and all the research you did, it was just incredible. I think the one thing we can take from the 70s, we will not be beaten. We can take that. And that domestic violence is real medicine. And then you really walked us through that the evolution that this domestic violence was seen as a private matter and now is a public concern. And as journalists, as health professionals, as concerned citizens, we want to shine a light on dark places. Thank you, Dr. Sheridan, Dr. Campbell, Dr. Jacquet, for being here today. And thank you to all of you here for this informative session. Thank you very much.